Hello, my name is Rachel, and I am the Research Support Coordinator at The Cure Starts Now. And today we are catching up with another one of our funded researchers, Dr. Rao, who is at the University of Texas Health Science Center at San Antonio. Welcome, Dr. Rao.
Thank you. Thank you for having me.
Hey, so Dr. Rao, in 2024, you were given a grant from the Cure Starts Now in the amount of $100,000 to explore a research question, which was the role of a protein called SKP2, exploring its role in driving and how it drives tumor growth and radiation resistance in medulloblastoma. Today, we'd love to hear an update on your research and how things are going.
Thank you. Thank you all for joining. So this research revolved around medulloblastoma, which is a pediatric brain tumor, which is the most prevalent malignant brain cancer in children. And while the advances in treatment have improved, the long-term survival of these patients, of which a significant percentage of group 3 and group 4 patients still face high-risk disease, which is characterized by alarming rate of recurrence within 2 years of treatment. And even those patients who do survive, they often endure a diminished quality of life due to harsh side effects of radiation and chemotherapy. This project revolves around a pediatric brain tumor. It's called medulloblastoma. And what we learned that these cancers have a unique dependency on a protein called SKP2. And so normal cells don't really rely that much on this protein, but this medulloblastoma, this pediatric brain tumor, relies heavily on this protein for survival, for self-renewal, and this protein also plays a role in conferring radiation resistance. And that becomes a big issue in these patients because these patients are treated with a very high dose of radiation. And if these cancers are refractory or resistant to radiation, that these patients won't respond. And that results in very unwanted outcome ultimately. So what we discovered that if somehow we can block or we can inhibit the signaling coming out of this protein, we can make these pediatric brain tumor cells more responsive to radiation. And in this process, we also discovered that this SKP2 plays a very important role in sustaining the growth of medulloblastoma cells by making them more addictive to glutamine, which is a non-essential amino acid. And so that means that these brain tumor cells require they have a higher need of glutamine. And normal cells also need these amino acid, but medulloblastoma cells need even more. So if somehow we can block that signal coming out of SKP2 and also the uptake of glutamine, then we can theoretically kill these cancer cells.
Interesting. So to summarize, um, you learned that you called it skip two. Is that what you called it?
That's
Skip
correct.
two. Okay. Skip two is drives tumor please correct me if I'm wrong, but skip two drives tumor growth, but also makes the cancer very addicted to glutamine.
Yes,
And the thought is that by cutting off glutamine, uh, you could potentially make the tumor more vulnerable.
that's exactly correct. So the way SKP2 sustains the growth of medulloblastoma or pediatric brain tumor is through the glutamine pathway. So any protein, when we say that it plays a role in cancer growth, it doesn't work by itself. it has several other partners which play a critical role in mediating the effect of that protein, which is causing cancer, or which is sustaining cancer growth, or which is making cancer not respond to the treatment, for example, radiation. So in this process, SCIP2 acts via genes involved in glutamine pathway. So the genes which are critical for glutamine uptake, the genes which are critical for glutamine transport, the genes which are important for glutamine metabolism. So if we can either hit or suppress or block SCIP2, or we can block the signaling coming out of SCIP2, which ultimately leads us to the glutamine pathway. So if we can block somehow the glutamine uptake as well as metabolism, we can basically not only block the growth of these tumors, we can also block the self-renewing ability of these cancers. And therefore we can basically, and you can also sensitize the response of radiation. So you can achieve several things by blocking this glutamine metabolic pathways.
Amazing. So, what is your understanding of what are some existing drugs that either block SCIP2 or block the glutamine pathway?
Very good question. Unfortunately, we do not have a very specific inhibitor or any drug which directly blocks SCIP2. We have inhibitors, but those inhibitors they don't cross the blood-brain barrier, for example, or they are not that specific, or they are so therefore they don't have any use for children with brain tumor. If the drug cannot cross the blood-brain barrier, it cannot reach to the brain, and therefore it cannot have any effect on brain tumor, first of all. Second, these inhibitors are not very specific, so we cannot use them in clinic right away. And we don't really know what they're toxic or not toxic. So what we do have is that there are several glutaminase inhibitors are being currently tested in the clinic. And we have discovered that one of those inhibitors can be used to treat this medulloblastoma patient. And we are actively collaborating with investigators and multiple centers to bring this inhibitor, which is currently being tested for adult cancers. We have shown that this glutaminase inhibitor can cross blood-brain barrier, can kill medulloblastoma cells, and can also sensitize radiation response. So therefore, glutaminase inhibitors can be used for treating medulloblastoma patients without any delay. We can bring them because they're already in clinic, tested for something else. So we can use them to test their efficacy in medulloblastoma patient.
Okay. From the adult trials, are you aware of any preliminary data that has come out of the adult trials, either about toxicity or efficacy, anything that you've gleaned from those trials?
Yeah, so the one inhibitor which has been tested is a CB839, which is a glutaminase inhibitor. It was tested in renal cancer, I believe. It was well tolerated, but the efficacy was not that dramatic. What we showed in our study that these medulloblastoma cells are uniquely addicted to glutamine. And so we have very good evidence with the same dose which they have used in clinic for those adult cancer cells. We see very good response in our preclinical model and in our most physiologically relevant models where we collect the tumor tissue from the surgery room and we don't manipulate them. We culture them the way it is. You can call it organ on chip. And then we test the efficacy of this drug and we see phenomenal effect. In addition to our murine models or mouse models or patient-derived models, we have seen in all these models very good efficacy of this inhibitor. So in addition to that, there are several other glutaminase inhibitors in clinic. One is from MD Anderson Cancer Center, and we have just had a MTA, an agreement with MD Anderson Cancer Center, which we would like to use that inhibitor, which is also blocks glutaminase and we will try to bring that in clinic as soon as possible.
Great. Okay, so kind of wrapping up, over the next maybe 2 to 3 years, what do you see coming down the pike, whether that's clinical trials or new research questions that are coming out of the research that you've done? What are kind of your hopes for the next couple of years?
We are excited about our study. We are excited about the clinical aspect and translational aspect of this study. And especially we are excited about because this drug, we found that it's highly effective in group 3 patient, which are these patients have highly aggressive cancer, and they don't respond to drug that effectively, and they relapse. And when they relapse, it's very hard for these patients to survive. So we believe that this study, which is highly translational, can be used, can be taken to clinic within 1 or 2 years, because the inhibitors which are already been tested for adult cancers, we don't have to reinvent the wheel for their toxicity. Their already toxicity profile have been identified. So we have to just start a trial by consenting these patients and test the efficacy of these compounds for the medulloblastoma patient. So theoretically, there should not be any lag time to bring these drugs in clinic.
Okay. And then my last question is, you mentioned MD Anderson, but we, know that any kind of hope or promise of new treatment requires a lot of work and a lot of collaboration. So who are some of the key stakeholders maybe over the next couple of years that will be exploring this option more closely and potentially opening up treatment options for patients?
Right. So any pediatric cancer or children cancer trial, these trials have to be started at multiple centers, because you don't have hundreds of patients in one center. And to really see the effect at a larger population, you have to start these trials in multiple centers. So MD Anderson is our partner. We will be initiating trials here at UT Health San Antonio. We'll be starting trials at MD Anderson. We'll also be working with Poetic organization to start trial at multiple other centers, so that we have a number of patients now enrolled in this trial, so we can see basically whether this drug is working or not working, right? So there will be multiple players, including MD Anderson, including Stanford University, which comes under the Poetic organization, and our UT Health. There will be multiple institutes involved and universities involved in this trial.
Well, thank you, Dr. Rao, for joining us. It really was a pleasure to hear an update on your research. Thank you for all that you're doing on behalf of our families and kids. So thank you for everything, and we really look forward to seeing what comes next.
Thank you for having me.